thank you very much for your introduction and for giving me the opportunity to talk to you all at this very, very interesting meeting. So I've been told to keep it a little bit briefer than the other talks, and I'm started with my title, which is a little bit briefer than the one you have in your book. And it's obviously a bit more focused on truth-telling and on not unexplained symptoms, but on conversion disorder. And I think of conversion disorder as being one of the paragons of an unexplained syndrome. And so hopefully much of what I say you'll be able to generalize to other unexplained symptoms, though there are important differences which I'll come to. I'm also mainly going to be talking about neurologists because those are the doctors that I studied, but again, much of what I might say would generalize to other physicians, though, again, there are important differences, and I'll come to those as well. I got interested in this area about 10 years ago when I first saw conversion patients and was really struck from the very start that there was this atmosphere in the specialized clinic where I was doing my training at the time of mistrust, of deception going on. There was a feeling that somehow the patients weren't quite being honest with the doctors and the doctors weren't quite being honest with the patients, that it was very different from the experience that I'd had, certainly in medicine and also significantly in psychiatry prior to that point. And I thought this would be something that I wanted to study a little more closely. So I'm going to say a little bit about conversion disorder. I know we've talked a lot about it in this meeting already, but for the non-clinicians here, some of this definitional matter is actually very relevant to what I'll be talking about for the rest of my presentation. So these are actually the diagnostic criteria from DSM and the ICD, very, very similar. And it presents with symptoms that look neurological, but where no neurological explanation can be found, but where a psychiatrist presumably feels they can offer some kind of psychological explanation for their presentation, and where the patient's not simply pretending. And I'll give you an example. A patient that we saw who had a terrible life in the way that psychiatrists are very familiar with: broken home, child abuse, foster families, broken foster families, drug abuse, and found a very supportive partner who was really her bedrock, but who couldn't put up with it eventually and said he was going to leave her, at which point she collapsed, had a kind of a seizure, and was left paralyzed down her left side, I think. So she looked like she'd had a fit, she looked like she'd had a stroke, but importantly, when the neurologist examined her, they found that she hadn't had a stroke, her EEG was normal, and moreover, they showed that it couldn't really be a stroke or anything, giving her a normal kind of neurological weakness, because they could trick her into using the arm or the leg in ways which she said she couldn't. So if it was neurological, it certainly wasn't neurological in the usual way. And the psychological explanation, well, it was obviously something to do with her partner leaving her because she collapsed as soon as he said it. But quite how that gives you a weakness, well, I think that's beyond most of us. Was she feigning? Well, who knows? But certainly we were happy to say that in her case she wasn't. But the fact that that's in there is extremely interesting because it's in the diagnostic criteria for conversion disorder, and it isn't in the diagnostic criteria for most conditions, even though people obviously feign depression or PTSD or psychosis or any other psychiatric disorder. But it's a diagnostic requirement in conversion, and I think that tells you a lot about where it has come from and about the experience as well of the doctors who treat it. It's pretty common. In fact, studies in Scotland recently have shown that it's the commonest condition seen in neurology outpatients, at least. Mainly affects women, as we talked about. And it's all round a problem, and it's a big problem for neurologists, who are the people who mainly treat conversion disorder. In the way it's supposed to work, I guess, is that you see a neurologist who refers you to a psychiatrist, but that is fraught with difficulty, and so at least initially, it will usually be handled by a neurologist once they've gone through the ER and so on. And they'll be the ones who are doing the difficult business of telling the patient that they don't think it's a stroke, they think it might be something else. And it's interesting that they are the people who do that, and that's what I wanted to study, because of course neurologists are, at least in the UK, where my study was done, quite a different group than certainly psychiatrists, and at least according to our caricature, quite different to the rest of doctors. They are, by legend at least, a notoriously obsessive group. They're very concerned with obscure diagnoses. They have little interest in the sort of human characteristics of their patients. They are really preoccupied by mechanisms that have no bearing on the patient's recovery. At least that's the caricature that I had as a student. And so it's perhaps a coincidence, but if so an unfortunate one, that this really cold and unfeeling group are in charge of this very difficult, emotionally volatile group of patients. Or is that a coincidence, or is that somehow a cause of the problems that neurologists and psychiatrists certainly get into in their management of this condition? And how do neurologists feel about it? Well, I'm going to be presenting some data. And I did 2 studies on this, really. I did a survey of all the neurologists in the UK, and I did a lot of interviews with individual neurologists as well, asking them about what they thought conversion disorder was, and asking them what they did about it, how they talked about it, and how they managed it, really to get at this idea of whether there was an honest and frank exchange or not. Now, none of my material thus is directly observing doctor-patient relationships. I don't have the benefit of Marcus's exposure to that. I've seen a lot of patients myself after they've seen the neurologists in the psychiatric clinic. And I know that from their descriptions and from the neurologist's descriptions, it was a very difficult relationship. And before I get into my data, just to give you a little bit of background to this, neurology really started in the sort of 19th century as a distinct discipline. And the person on the left is Charcot, who we've heard talked about quite a lot today. He was arguably the greatest neurologist of all time. And he took an interest in conversion disorder, or hysteria as it was then known, and he came up with a theory that, again, some people have talked about. But Freud, who was one of his students, said something very interesting about Charcot's achievement, which was essentially that his greatest achievement, as he put it, was to restore dignity to the topic. The patient would not necessarily be greeted with the smile that they would heretofore have been greeted, because he had lent the weight and dignity of his position to the disorder, to the authenticity of the phenomena. Neurologists, up until that point, had been used to dismissing hysteria as some kind of pretense. Clearly wasn't neurological. It didn't fit with the anatomical and physiological knowledge that was growing at the time, and it looked in some way to be pretense. And he restored the dignity of the topic by saying, well, no, it really is neurological in some other way. Now, it didn't survive his death, in fact. Ultimately, it perhaps did more harm to the topic than saved it. And if it was saved by anyone, it was saved by Freud, who produced his theory of the unconscious and so on, based on his experiences with conversion disorder. But it was saved by Freud, though who may have been a neurologist originally, but it was saved in what came to be known as really the psychoanalysis and ultimately by psychiatry. So where does that leave neurologists in their thinking about it? Do they revert to this idea that if it's not anatomically or physiologically possible, then it's some kind of pretense? Do they buy into this psychiatric idea, that slightly outlandish model? Well, who knows? And that's kind of what I wanted to find out. But I'll start just by showing you this one slide from the survey, asking them whether they really thought it was a neurological problem. And clearly, they don't. Some do. That's about 10% of them said they thought it was a neurological problem, but clearly the vast majority don't. Some said, well, one day they could imagine that it could be in some other way, but the vast majority, over 60% there, said that it could never be a neurological problem. This is not neurologists' matter that they're having to deal with. This is someone else's, presumably psychiatrists' problem that neurologists have to spend so much of their time dealing with. So, what do neurologists think conversion disorder is? And I guess they divided up into 4 clinical groups for me. Clearly there are neurological disorders, your MS, your myasthenia, your motor neuron disease, and there are things that are unexplained, but not in a very interesting way, and they would talk about a little funny feeling here or something that might upset a patient. They might come to the clinic saying, you know, I feel very strange, I've been a bit dizzy this morning, it's gone now. And the neurologist would say, well, or felt about these kinds of presentations, that they probably were neurological. There probably was some kind of physiological occurrence that accounted for this, but it was never going to be investigated, it was never going to be diagnosed. It was thus unexplained, but not in a very interesting way. And they contrasted that with conversion disorder, which was really too inconsistent to ever be organic in the way that I explained. So they would do tricks that would expose this inconsistency. And that formed the cornerstone of their diagnosis. They would get the patient who was weak in one side to move whilst doing part of their exam, even though they said they couldn't move that limb, and so on. And then there were these psychological models. So there's for conversion disorder, which they did endorse. And they said this is something that they knew about, but they endorsed it really in a very distanced manner. They would say this is something that they'd read about, something they'd heard about, something that they'd been taught about perhaps, but it wasn't really something that they engaged with themselves. And the reason that they would give was because they said it's not their responsibility, it's not their area of interest, it's not their area of expertise, as one memorably put it. And the things in italics here are quotes from the interviews. One said, I'm an electrician, I'll tell you about the hard wiring. So those are the 3 groups. We have the neurological, we've got the unexplained in an uninteresting way, we've got conversion disorder, and then they've got feigning in some form. And their understanding and relationship with feigning was very, very complex, as I had anticipated. It was a big topic for them. Most of them didn't think conversion disorder was just feigning, though some did. And about half of them, more or less, said that they were distinct disorders, that feigning and conversion disorder were separate. But the reasons that they would have for that didn't really bear scrutiny, it seemed to me, and were sometimes nakedly on the basis that they didn't want to think otherwise. I would find it truly horrible to consider that patients are putting it on for conscious gain. And consequently, lots of them remain suspicious. They might say these are separate disorders, but they weren't sure. The number of people I've seen over the years and I've thought, is this person malingering? Are they putting it on for my benefit? I've never really been able to sort that one out, they might say. And then there was another, approximately half of the group, who said, you know what, I don't think they are distinct. I think they overlap in some way. Typically they'd say, well, they're on a spectrum. There's an admixture of it. Conversion is not malingering, supposedly, though I find it very difficult to draw the line very clearly between the two. And then others would say, well, the distinction is kind of misguided because deception is a feature of life, if you like. We're all at times insightful, at times we're not insightful. We're all at times honest and dishonest. And really, this is just from the survey again, putting numbers onto that and showing that's conversion and feigning are the C and the F. that roughly half thought they were separate, but a sizable group there, about 13%, think that all conversion patients are feigning, or that all feigning patients have conversion disorder, that they're effectively variants of the same thing. And I came to the conclusion, really, that this idea of feigning, or at least of deception, was central to the neurological view of conversion disorder. And if you think about the position that a neurologist is in, the neurologist is given a patient who presents with seemingly neurological symptoms. They present with the seizure that I described, or the weakness, with what looks like epilepsy, with what looks like a stroke. If you like, a simulation of this disorder, and I say that non-pejoratively. And then they're asked to make that distinction. Is it what it looks like or not? And that's as far as they want to go. That's as far as they feel able to go. There is this extra idea that they've been told about, that some of it might be subconscious, or that it might be feigning, but that's not a decision that they feel able to engage with, or a decision they feel able to make. That's someone else's responsibility. So as far as they're concerned, all that they've established is that this is a simulated neurological condition that may or may not be pretense. And it's the establishing of that simulation that is the core of what the neurologist is doing. Now, there was some data from the survey and from the interviews that backed that up, but that was in large part my impression. I mean, one of the key things I think that did support it was the extent to which neurologists would bring this up without thinking about it, because I did feel that they were sensitive to this topic and were in some ways slightly reluctant to talk about it. But they would bring it up almost by accident. You'd ask them to talk about a classic case. What's your most memorable case of conversion disorder? And time and again, they'd come up with cases of feigning. And sometimes they'd correct themselves and they'd go, oh, no, wait a minute, sorry, no, that's feigning or something, that's malingering, that's not conversion disorder. But it happened time and again, both when in the survey and in the interviews. Okay. So that's, in a nutshell, what I found about the neurologist's understanding. There's these four kind of distinct modes. Underlying it all, I felt, was this idea that there was a deception going on, and whatever else was happening wasn't their problem. How do they talk about it? What do they say to the patients? Well, the first thing to say is that they don't want to talk about it. They are reluctant to talk about it, and they compared it to talking about a terminal illness in their reluctance to talk about it, until they had no choice. And in parallel with that, they would investigate continuously as a way of avoiding talking about it, coming to that final conclusion that this is conversion disorder. They would keep on investigating, hoping that they would find something, as of course if you investigate long enough you will find something, that would mean they wouldn't have to talk about conversion disorder. And they'd say, well, here's a quote, "My worry is not to label patients with it, label them with conversion disorder, who've got a subtle underlying abnormality that's elaborated." So even if they find some very subtle abnormality, then that's great. You don't have to label them with conversion disorder anymore. You can now talk about a subtle underlying abnormality. I found that they didn't talk about feigning, and they didn't talk about it even if they were sure that the patient was feigning. So even when they were absolutely sure, 3/4 of the neurologists said they would not talk about it at all. And sometimes there were explicit examples of what I've rather pejoratively here called diagnostic cowardice, where they didn't give the right diagnosis. They gave a misdiagnosis, or they allowed a misdiagnosis to be perpetuated. A lady with multiple sclerosis was the hero of this and that. I think she was president of her MS Society or something like that. She worked terribly hard for people. I couldn't find a neurological sign, so he knew it wasn't neurological, and I just went, "I think you're doing really well, and I don't think there's any need for me to see you again." So that's a clear case where the neurologist has diagnosed at least that this is not MS, at least that this is not neurological, and yet he is allowing her to believe that she does have MS. And that's quite explicit. But there were also much more widespread than that. I think those cases were pretty rare. At least it was rare that the neurologists would talk about it. But much more pervasive was a sort of diagnostic soft peddling, where they would talk about it, but they would talk about it in a less direct manner. And there's lots of ways in which this was clear. I asked them about what their favorite model was, or what their preferred model for understanding conversion disorder was, and I offered them various options, including some that were clearly psychological, is it a subconscious process? Some that were more behavioral, is this abnormal illness behavior? Is this feigning? Something like that. And they all told me what they thought. And then I asked them what models they would use when they were talking to patients, and they didn't line up. They tended to talk about things with patients in ways that were more psychological than the one that they preferred in terms of the way they understood the condition. And this idea came up throughout, that they talked about the psychological aspects. They talked about how this might be a conversion disorder only as far as they felt the patient's response to them would allow. There's an example here. I bring up the issue of stress and see how they respond to that. If they're adamant that's not an issue, then I will just go through the motion of just excluding the organic pathology. Okay, that's a very typical sort of response. He's trying to talk about conversion disorder. He feels there's resistance, and so he drops it. Now, I think about what the diagnostic conclusion of that is, if you will, for the patient. Well, it's not clear, but we're left with the possibility that rather than this patient coming away with the conclusion that they have a conversion disorder or feigning or something like that, that they have been told, well, I haven't managed to find an explanation for your problem. I'm afraid that's as far as we can go. We're kind of left to the patient's own thoughts on this, but my guess is that most patients are going to conclude from that they've got an unexplained neurological problem. Neurologist can't find it, but when I told him it wasn't stress, he seemed to accept that. And when they did talk about the psychological, they talked about it in a very non-committal way. Again, remember, this is neurologist reports on this. This is not patient interviews, so it is to an extent interpreted, but here's one clear example. A neurologist describing that it might be that your brain in some way, because of some psychological distress, is manifesting this problem. I mean, that's not an unreasonable thing to say, but it's clearly hedging his bets there, the neurologist. He's saying it in such a way that he's not saying, you do have a psychological cause for your problem. He's saying, it might be in some way. It could be happening, which obviously leaves open the possibility that it isn't happening. And it's up to you, the patient, to conclude from that what you will. It may be happening, it may not. The diagnostic conclusion from that is left open again to the patient. And then the last aspect of this was in the letters. In the UK, it's now standard to copy your letter to the patient. When you write to the patient's primary care physician about your encounter, you're supposed to send a copy to the patient. That's been a fairly significant change in the last few years. So the patients know what you have written to their GP, as we call them. And the neurologists, by and large, said that they used codes. Not always, but almost all of them said they would with conversion disorder some of the time. They used codes. And what was the code saying? Well, that would vary, but typically what they were trying to say is you've got a conversion disorder. They want the primary care physician to know you've got a conversion disorder, but they don't want the patient to know. And they've got various codes that they would put in the letter that the patient wouldn't understand, but the primary care physician would. So they're allowing this diagnosis to be concealed again. Okay. So, what's going on here when we've got this? I mean, the case I gave you with the president of the MS Society, it was fairly clear what was going on. The neurologist was perpetuating or allowing to be perpetuated a falsehood about her diagnosis. What's going on in the other cases is obviously more subtle. And you have to think about this from the perspective of communication more generally and how that is carried out, because it's clearly much more than what the neurologist says. We all know about the impacts of body language, of emphasis, of tone, and so on. But obviously that's very difficult for me to assess. I didn't have access to any of that. And it's very difficult to describe that kind of thing systematically as well. But at the same time, there's clearly much less than the words that are said as well, in that people are often drawing very different conclusions than the words would seem to justify. And I'll give you two cases there of patients whom I saw in the clinic after they've seen the neurologist, perhaps a long time after they've seen the neurologist. When they would say to me, this is not uncommon that patients present with an angry description of their encounter with a neurologist or some other doctor. But in this case, what was interesting was they said, I can't believe that terrible Dr. X. They were so awful. And I'd go, oh dear, I'm sorry to hear that. And what did they say? And they'd say, well, they told me that I had a subconscious problem giving rise to my symptoms. And I'd go, okay. And they go, can you believe that they would accuse me of pretending? And I'd be kind of flabbergasted by that for a moment. And I'd be wondering, how can they have put those things together? Is it just that they haven't understood what subconscious means? But one of the people who told me that was themselves a psychologist, okay? So what's happened here? What's the encounter with the neurologist? How have they come to this extraordinary conclusion on the basis of what's happened? Now, as I said, I think that the idea of deception is very important to neurologists thinking about conversion disorder. One way of thinking about this, of course, is that the other aspects of communication are coming through. That the neurologist is betraying, if you like, what they really think. And remember, I said they don't talk about feigning, ever, even if that's something they might be thinking about. But of course, they may be betraying that in some way. Maybe that's coming across in their speech, even though they say, well, it's subconscious. There may be other clues that they're giving that the patient who's very sensitive to this is picking up. One clear example of this is to talk about real. Okay, this is, if you like, a mistake that so many of us, including myself, fall into is when we talk about conversion disorder being not real in the same way as something like multiple sclerosis. Now, something that I would always correct if I caught myself doing, but people do it. Everyone does it, I think, somewhat. I'm sure a patient who was sensitive to the idea that they might be feigning would pick up on that extremely quickly. But then I think there's a slightly bigger point here, which is that communication is a complicated business. And I have given you descriptions that the neurologists gave me of how they communicate. But communication requires two parties. It's meant to be cooperative. It has to be cooperative because typically what you say to someone is very incomplete. The way that you would ideally communicate is supposed to adhere to these, the principles that H.P. Grice described of quantity that's just right, of quality that's just right, of relevance that's spot on, of a manner that's appropriate. But almost none of us do that, ever, not just when we're talking about conversion disorder. And people have to fill in the blanks. They have to make inferences to what you would have meant in an effort to understand. Now, the important thing about that, of course, is that when the patient has to make inferences about what you meant, then there is room for error, and there is room for you to deny that interpretation. So how should you diagnose conversion disorder? Well, the clearest way to diagnose it is to say, I diagnose you with conversion disorder. Now, I'm not sure that anyone has ever said that to a patient, and I don't think I have. More typically, I might say, well, this looks like conversion disorder, something like that, which is perfectly idiomatic, perfectly appropriate, but it obviously reduces my commitment to that. Patient gets angry and says, wait a minute, are you saying I'm faking it, or are you saying I'm crazy or something? I can always deny that and say, well, I didn't say you had conversion disorder. I said it looked like conversion disorder, you know. there's room for me to deny plausible deniability, you might say. And in general, the kind of communication that the neurologists were describing is much more indirect than that's the canonical model of I diagnose with you with conversion disorder. They were much less committed to what they were saying, or what the point of their diagnosis should have been. And that allows them to deny it. It allows them to say things which they don't entirely believe. It allows the patient to save face. It allows them to remain tactful and polite. There's lots of useful things which are vital for everyday communication, but also have lots of useful features. Now, it's not to say that directness is the answer. You know, if I were to say I diagnose you with conversion disorder, I'm sure that would lead to problems of its own. It's extremely aggressive, and it's also not by itself clear either. On the face of it, it's just a form of jargon, and it could be used, again, to obscure my true meaning. And Kurt gave a couple of very nice examples in his paper of how the use of such clear and direct jargon can also lead to the conclusion that the patient has either an unexplained neurological condition or a diagnosed neurological condition. And the quote I've given you there relates to the use of functional, which, again, is a useful word and that lots of doctors like to use, particularly neurologists, when they talk about conversion disorder. And one of the features of that is that it also is highly ambiguous. There are lots of meanings of functional, and at least some neurologists are aware of that and benefit from it, they feel, when they talk about the condition, because it allows the patient to think one thing about what you've said whilst you perhaps have meant something else. And the quote is, enables you to say that it doesn't fit, enables you to say that it's not neurological without actually having to speculate on the psychopathology. You've left that all ambiguous and on the table. So the point really is just that good communication is a skill. It's not something that you can say clearly you have to be direct or you have to be indirect. It's something that we all learn from birth and we're all pretty good at, but we're also pretty good at violating it. We know how to speak about matters in an indirect way. We know how to speak about things in ways that are less challenging and also less clear, and how useful that can be. And that is what the neurologists are talking about when they talk about the way they describe these issues. So why do they do it? Why is there this reduced commitment? Why are they not talking about it with the clarity that on the face of it they should? Well, the big reason that everyone talked about was therapeutics. It's not a good way to keep your patient engaged in your clinic, to belabor them with a diagnosis that you think they're not going to like. So you keep their trust, ironically, a little more if you allow them to believe something that is less offensive to them. You'll keep them engaged in your clinic. They will save face, they won't be humiliated, they won't have to leave, and you can build up a relationship over time that is ultimately more beneficial to the patient. And then on a more sort of personal level, they all talked about the difficulties of being direct, something that they had seen, they would all say, in their own training, as though this was a way that neurologists spoke in the past. They'd all seen their mentors force the diagnosis on patients, leading to terrible arguments, the patient storming out, and a feeling that this was always a very, very fraught encounter. And this was something that they didn't want to replicate in their own practice. They obviously didn't like complaints which arose from upsetting patients, and they wanted it to feel good about what they were doing. And that's something they said repeatedly. They said, you psychiatrists, you're used to patients being angry with you. You're used to patients not liking you, but we're not. We're very uncomfortable with that. And we're used to patients saying, thank you, doctor, and, giving us gifts. The two things are dislike of conflict and the desire that when somebody leaves the room, they don't hate me. And then the last reason they gave was that they didn't think that the values that they saw as being inherent in making either a diagnosis of conversion disorder or feigning was really their responsibility. Accusing someone is not part of their job. It's not your job to make any sort of value judgment about the patient. So those are the reasons that the neurologists themselves gave for the way in which they underdiagnosed, if you like, conversion disorder. The question for the ethics conference, I think, is this right? Can we justify this ethically? Because on the face of it, what's happening is that the neurologists are not really telling the truth about conversion disorder. They're not respecting patient autonomy to the extent that we have understood we all should be doing. Can this be justified? And there are three ways in which I think traditionally you can justify this sort of approach. And I think they're all good arguments, and I think they're all better arguments in the case of conversion disorder, where they seem to have more bite. The first one is that, respect for autonomy is a great thing, but it's not absolute. It can't apply completely and not to every case. You can trump it with things like beneficence. You can trump it by non-malfeasance. You can say that we don't have to do it if there are other priorities. And this is a perfectly reasonable argument. This fetishization of autonomy that's become so popular is a new thing. Hippocrates didn't talk about it. We didn't talk about it in the last century, the 19th century. It's a kind of relatively new idea that this autonomy is all important, and various philosophers have criticized this idea as being either a fantasy or at best a sort of an unhelpful idea when what is more important is the overall care of your patient. And certainly there seemed to be the idea that the neurologists were themselves advocating. My concern about this approach is really twofold. This model that you might have of maintaining a therapeutic relationship relies on the idea that you're going to be able to maintain a therapeutic relationship. And I just don't think healthcare works like that very much these days. I don't think many neurologists are going to keep many of their patients coming back to see them every week to build up this diagnostic relationship that would eventually allow them to say, look, we've known each other for 3 years, and now I can finally tell you in a way that you're going to accept that you need to see a psychiatrist. I'm not saying it doesn't happen. It definitely does. But I think it's not going to be that common that you're going to be able to build up that relationship these days, at least not in the UK. And the other thing is that I think that the information, the idea that is being withheld here is so important. It's the most important aspect, arguably, of the entire encounter with the doctor, finding out what's wrong with you. This is not some remote side effect that can be ignored. This is not an aspect of their care that can be put off. This is the core idea. This is why the patient has come to see you, arguably. They want to find out what's wrong. And if you're not letting them know that, you really are making some judgments about what's best for that patient that they very likely would not support if they knew. The second argument is that the patient really doesn't want to know. In fact, you are respecting their autonomy because they're telling you that they don't want to know what this idea about conversion disorder. They don't want to know, so you don't have to tell me. And they show this in various ways. There's the resistance that Marcus was talking about yesterday. There is, and in fact, as a result, if you like, the neurologist is just being a good communicator. He's adapting, he's cooperative with the patient's resistance. He is adapting what he discloses to the patient in a way that is really reflects the realities of what the patient is telling them they want to know. And I guess I have a few problems with this as well, though, again, resistance is clear, and yes, patients clearly don't like the diagnosis, but cancer patients don't like the diagnosis either, and you would not want to withhold the diagnosis ultimately from a cancer patient. even if they got angry afterwards. And they would say that they had wanted to know. And psychiatric patients say they would have wanted to know. And we also know from what Marcus and others have shown us is that doctors really aren't picking up resistance, or at least that's not what they're reacting to. Resistance is definitely there, but actually doctors aren't very good at picking it up in specific cases. And what you're really getting is the doctor's fear, the doctor's judgment about whether this is going to be comfortable for them. And the last argument is that really you can't tell the truth about this. It's impossible or it's too difficult. And the argument here is that the diagnosis is extremely complicated, that conversion is going to overlap with feigning perhaps, or with a degree of some unexplained neurological problem, that I don't really understand it, so how can I understand it? How can I explain it to you? And perhaps you're not sophisticated enough to understand what's going on, or you're not ready to understand what's going on, as Grant was talking about yesterday. That there's really some barrier that makes it practically impossible for me to tell you about this. And again, I do have sympathy with that point of view. But I think the best critique of this came from Celia Bock, where she compared this kind of defense really asked you to imagine how you might feel if this defense was applied by a used car salesman who had not told you about a serious problem with the car that they were offloading on you. And they said, well, I thought the most important thing was that you got this really great car and you didn't need to know about the suspension problem. And you didn't seem to be interested in finding out about the problems. Or, the last one, it's really difficult to explain these kind of suspension problems. That's a really technical thing, and I didn't think you'd understand the intricacies of it, so that's why I didn't tell you. The bottom line is that patients have time and again said that they do want to know about this, and if it's difficult, they want your best guess. I think saying that telling the truth is impossible is confusing telling the truth, which is obviously impossible because truth is impossible to get at, but that confuses that with the attitude of truthfulness, of approaching the patient with a desire to tell them what you can. And then finally, really, so does it matter? If there is this diagnostic gap, and even if it can't be justified, what is the harm? Why should we concern ourselves with this at all? Now, obviously, if there's a misdiagnosis, if the patient believes that they have MS rather than conversion disorder, the potential harms are quite serious. They might take drugs that are bad for them. They might not get the psychotherapy that might be helpful. They might find out about it and know that you didn't tell them the truth. They might be very upset and never see a doctor again. This idea that patient groups that we were talking about over dinner last night, why aren't there any patient groups? Well, it's because too many of them think that they've got MS or motor neuron disease. They don't believe they've got conversion disorder. I think all of these things are true. I think in practice, the risks may be more hypothetical than actual. I think that the types of misdiagnosis that's going on here between an unexplained neurological condition, if you like, and a conversion disorder, the availability of treatment and our knowledge about treatment is unlikely to make much difference to what happens to the patient in practice. But surely the biggest ethical question really is about lying. Is the doctor lying to the patient here? And that's clearly enormously important from an ethical point of view. If the doctor gives a misdiagnosis or allows the patient to believe something which they know is false, then that would seem to me to be a very serious violation of what we understand today to be the ethical code of doctors. But is that happening? And I want to talk about two ways in which it might not be happening. And the first is that when we tell people things that aren't true or allow them to believe things that aren't true, we're not necessarily lying to them. If I was a stage actor and I said, I've murdered my wife, you wouldn't call the police, and when you found out that I hadn't murdered my wife, you wouldn't be angry with me, because you know I'm not telling the truth. You know that even though I'm trying to convince you with all the passion I can muster that I really have murdered my wife, in this situation, you're not to trust me. If I'm a stage magician and I say I've got nothing up my sleeve, and it turns out really I have, you wouldn't be upset afterwards. You wouldn't say, you lied to me, you said you had nothing up your sleeve. Why is that? I want to convince you I've got nothing up my sleeve, but I have. Why isn't that lying? Again, it's because the expectations that you have in that situation are that I'm not going to be honest with you, and that I'm not going to be sincere. If I meet you in the lift afterwards and you say, Richard, that was the best talk I've heard all day, it was wonderful, and you don't mean it, I'm not going to be upset, because I'm going to think, well, in that situation, that's what you say to the speaker, right? That's tact. Okay. Now, you might disagree with that. There will be some here who would say, well, no, I think that would be lying. And that's the point about these things. These kind of expectations are normative, they're culturally relative, and they are definitely open to interpretation. But they are present, and they are present in all of our encounters. What about in the doctor-patient encounter? We're used to thinking this as being a situation of maximal trust, where you take everything very, very seriously. You think your doctor is being highly sincere in everything that they say, and that the patient is being absolutely scrupulously honest in everything they say. But that's obviously not always true. And I think we've got good reason for thinking that in conversion disorder, it might not be true to a considerable extent. And that's because there is this atmosphere of mistrust that I talked about, that I think everyone is aware of, at least in some cases. Patients will talk about their journey, and they'll say, you know, I've been through all of these doctors, none of them believe me, they all gave me this stuff, and, you know, the trust has broken down. And the point is that if I think you don't trust me, if I think, like the stage magician, that you're not in that situation where you're going to accept what I'm saying as sincere, then I'm not lying to you, whatever I say. I might be misleading you deliberately, but we wouldn't say it was lying. In that situation where trust has broken down. Now, it's an empirical question, of course, about whether trust has broken down to that extent. But at least I think it's theoretically possible, and in some cases, it's certainly true. But then there's the broader point, of course, which is that doctors aren't usually saying, you've got MS. They're usually allowing the patient to think they've got MS. They're not disabusing them of their preconceptions. They're saying things in a way which allow the patient's fears or desires for a diagnosis to dominate what they have said. They say things which are designed, if you like, to reduce their commitment to truth. It's not the same as saying, I diagnose you with MS. Is that lying? Well, I don't think it is. Technically, to be a lie, it has to be a sort of assertoric statement of some kind, and doctors are deliberately not doing that in order to reduce their commitments to what they've said. But they're still responsible, nevertheless, for what they've said. They're responsible for the communication. Even if we don't call it lying, they're responsible for their part of this cooperative communication. And even though that cooperation may have broken down, the patient is desperately reaching for a diagnosis of MS or picking up on their wildest fears that you're accusing them of malingering, you're not responsible for that. But you are responsible for your part in that, which is how clear and how effectively you are conveying the diagnosis to them. It's not going to get you struck off, but it is going to be on your conscience, if you like, about what happens as a result. Okay, Now, with that stark conclusion, I will thank my collaborators and welcome your questions.
So, Richard, that was the best talk I've ever heard. So, as I was scribbling furiously over there, so much of what he said resonates with me as a neurologist, and I wrote down all the descriptors of myself as a different group, including obsessive, and not interested in humans. But I'm going to move on. And you know, my greatest lesson really around this patient population or these patient populations, and I think about somatoform disorders and somatization and conversion, I learned the most by failing miserably. I took over a MS practice several years ago, an enormous practice that had been in existence for about 30 years, and I thought with my young, strapping knowledge that it was my duty to dispose patients of any misconceptions, mistruths about their diagnosis. And so I charged in there every time, and I said things like, you've been following with Dr. So-and-so for 18 years, I'm taking over your care, I was reviewing your record, and I'm here to tell you, fortunately, that you don't have MS. And those patients were angry. I was expecting relief. I really thought that as a neurologist, I was applying my black and white, AAN approved sort of knowledge that I had spent over a decade accumulating. And I was really stumbling with those patients. Those patients were angry, our relationships didn't work out, and I learned an enormous lesson. And so much later in my career, I've changed my approach to those patients. And one of the things that I pick up from the conversation here was that intention does matter. Richard mentioned that not only does it matter from a neurologist perspective in terms of whether or not the patients are voluntarily misleading them or whether or not the neurologist is being taken advantage, but also if I were to perpetuate a mistruth or not undo the mistruth, what is my intention as I'm doing that? That's very important to me to maintain sometimes my own integrity in whatever it is that I choose to, however I choose to communicate with those patients. And I always hope that with that intention, I'm taking the best care of the patient that I can. Maintaining that therapeutic relationship, I heard some giggles in the audience when he said, 3-4 years down the line, maybe then you can introduce the idea of this is conversion disorder. But I've had that conversation, and sometimes it occurs 3 or 4 years down the line. And in part, I think that's because being an effective communicator means that you know your audience. And oftentimes I have to learn my patient. I have to learn my audience before I can communicate effectively with them. One other thing that struck me was about how patients receive the news. As I said, I charged in there and I expected gratitude when I disposed people of a chronic debilitating neurologic illness as a diagnosis. And I was fairly stunned when that didn't happen in my own sort of egotism. And I have since experienced that there's a spectrum. When I go in and I am thinking about somatization or conversion disorder, I send out feelers. To feel how the patient might feel about that, or have they heard those words before, what their experience has been with other physicians, do they know somebody with these other illnesses, because those reactions from your patients, that information from your patient helps me dictate where I go. There are patients who I tell who are tremendously relieved when I take away a diagnosis or I give the diagnosis. And there are patients who become exceptionally angry. And I akin it to, you are rocking at times the psychosocial construct for many people. If you take away their belief system, whether that's a correct belief or an incorrect belief about their diagnosis. And that should not be done lightly. And so I'm very careful about removing and giving labels. Labels are very important to patients. They want an answer. And sometimes they will settle for an incorrect or a not diagnostically accurate answer over a diagnostically accurate answer. And it's important to understand how those roots ground a patient before you rip them up. This also makes me think, particularly in the US, about how neurologists are struggling with balancing patient satisfaction and truth-telling. Because nowadays, if you're unaware, we're graded now. And reimbursement will be tied to how patients perceive their interactions with you. And I know this acutely because I've been asked both to develop a communication program for all physicians at the entire Cleveland Clinic, as well as I am the patient satisfaction guru for the Neurological Institute. So I hear from physicians all the time, well, if I'm just supposed to make the person happy because my scores need to be over 90%, and I tell them that they don't have MS when they thought they've had it for 30 years, what do you want me to do? Which one am I supposed to do? This is a reality for docs now. In chronic pain clinic, right? If I give the narcotics, they'll be happy, and if I don't and I communicate effectively that I'm not going to, they're still going to be mad, and then I get a poor rate. So these real things weigh on neurologists, weigh on any physician, I think, in today's culture. And so that adds sort of a new element. And I think it makes this idea of labeling all the more relevant and should be approached with caution. But that's a struggle that I certainly have, how to balance those two things. Richard talked a lot about strategies for communicating, and I use several things. I'll comment on them briefly, and then I'm going to open up the floor to some questions after one other point. So for me, I lay down my sword, as I say. I've compared sometimes these conversations with patients as a battle or a wrestling match, and I think it's really important to lay down your own agenda when I walk into the room with these patients. And what I mean by that is it's much more important to get them talking than it is for me to be just blabbing about my knowledge. Because in truth, no one knows that patient better than themselves. And I shouldn't, nor do I any longer, charge in dispensing my knowledge without yet feeling like I have a very good understanding of these patients. And so one way that I do that is by I call it fifing patients, but asking them about how their illness, whatever it is, whether it's feigning or not, whether it's conversion or not, how it's impacted their life, how it's impacted their functioning, what fears they have around it, and what are their expectations. Because patients have all of those things. And you will not be able to deliver a communication program or a communication agenda unless you have an understanding of some of those basic things. If a patient's expectation is that you are going to send them to psychiatry and you keep them in your clinic for 3 years, you've failed them. If the patient's expectation is that you're going to rub their feet every time they come into your office and you send them on to, psychogenic movement disorder clinic, you're also going to have a disconnect. So some of these very basic tenets that we just don't say out loud, I found very successful in finding some inroads about communication techniques that will work. A few other points there are acknowledge uncertainty, not necessarily as a way out, but just I understand that I don't know everything about this illness. I also find respect, demonstrating respect for these patients. I can't believe that you have been struggling with this for 5 years. I can't imagine what it's been like seeing 80 doctors. I really appreciate that you've brought all of those records to me today. These comments, although seemingly silly, patients take a lot of pride in the fact that they're that organized, they've documented these things, it's valid to them, and it's no skin off my back to respect that effort and to validate what they've gone through and acknowledge it, say it out loud. I also acknowledge my own discomfort. This is a topic that I really struggle with. This disease process, I wish I knew more about. Because uncertainty, I think, can be used as an excuse. I don't feel comfortable diagnosing conversion disorder sometimes, or somatization, I don't know all the DSM-4. And so I can be very honest when I say there's uncertainty here. Sometimes I just don't know, but I'm willing to work with you on it. So again, that partnership, reinforcing that partnership. And lastly, the comment about the narrow interpretation of a neurologist or a neurosurgeon or a psychiatrist's responsibility is fascinating, because I hear it come up everywhere. And yet, to be able to say, I only see MS patients, you don't have MS, I've done my job, that feels kind of good. It just doesn't work that well. And so, for me, I try to remain curious about these patients. And I remember that before being a neurologist who specializes in MS, who only works in Cleveland, I'm a human and I'm a physician. I'm a doctor. And doctoring is not just, unfortunately, patients will never come to you with their nice bucket of MS. They come to you as a human. And all of that will need to be addressed sometimes. And I certainly strive to achieve that in these patients. So I'm going to open up the floor to questions and comments. So let's hear it. Silence.
No, I'm curious about, there must be patients, you mentioned that it happens, there must be patients who say, this is the best thing I ever heard. I don't have motor neuron disease. I mean, that sounds like the best news in the world. There must be some people who respond with a kind of joy.
There are a range of responses, and I think we all try and predict how a patient reacts, and I'm sure we all try and tailor what we say to that extent. But there are some people who say it's absolutely, as you say, this is the best news I've ever had. I think the majority of patients don't, at least at first, and those are aversive experiences for all of us. No one likes sitting for an hour with a patient who's angry with you, with their family all being angry with you. That's really difficult, and that's perhaps more common. I'm sure that's more common than having a patient say, "This is the best news I've ever heard."
So it is the case, I think we've talked about it throughout the whole conference, that there's something different about the conversion and somatization than almost any other illness that either neurologists or psychiatrists deal with. Better education of neurologists and psychiatrists, better education of the general public. Until we have patient groups, lay groups, that are interested in this. There's a multiple sclerosis lay group. There's a Parkinson lay group. There must be a schizophrenia lay group. There's no lay group of people who are all enthusiastic about their conversion disorder and are lobbying Congress for more money for research in this particular area. There is no research in this area anywhere, hardly any. This is a major problem, and I think that in recent years there is more interest and it's growing, and it's probably helping, but we're also having a lot of trouble. And I think this is part of this whole difficulty in talking with patients, because we're talking about something that isn't all that well defined, and no one's all that comfortable with it. Doctors aren't comfortable, patients aren't comfortable with it. So I think that we're in a particular crisis at the moment, which we may be working our way out of, but it's going to be a while till we get there completely. So I think we just need to keep doing more research and more working on this area, and hopefully we'll get better at it.
I recognize everything that you've talked about. My feeling about the cause of the crisis comes down to feigning. I think there are many factors behind it, but I think that's the biggest one. I think the distinction is so difficult for everyone, doctors and patients, families, that it makes the whole topic so uncomfortable. It's not a diagnosis that patients want to accept because they're unsure how distinct it is. Their families are unsure. They're certainly not going to be comfortable telling anyone else what they've got and boasting about conversion disorder whenever people say, but... Because certainly when I talk about patients with it, at a dinner party or something, people will say, well, that just sounds like they're making it up. It sounds like they're pretending. That's how people understand that kind of behavior.
Well, and because there's lack of knowledge about the situation.
Well, we talk about knowledge, but as you said, we don't have much knowledge at the moment. Yeah. You know, I have this fantasy that in the time of Freud, there was a fashionable disease. You know, that it was desirable and attractive, and that people would sit in cafes and tell each other about their hysteria and so on, and it would be... I have no idea whether that's true, but it's easy to imagine, I think, that it was like that and could be like that again. You know, when you finally prove that it is the temporoparietal junction that is aberrant, everything could change, I'm sure.
So maybe we'll take one more question, and we'll have to sort of start to wrap up. I know you have to slightly catch before you go on.
I saw, did you have, you're handing off your question?
Two of the things you talked about in the talk, I think, are very interesting implications for the DSM-5 revisions, diagnostic revisions. One key revision was in the job in the requirement of ruling out feigning, and I think this is for practical reasons. There's no reliable lie detection test. But I'm wondering, since you have made the point that you think this notion of feigning is very crucial, sort of inextricably bound up in our conception of the condition, what sort of long-term repercussions you see potentially happening if that takes place? And similarly, for the proposed name change, functional neurological disorder, you brought up the multiple potential meanings of functional, and I would add some of that maybe pejorative, but there's a certain advantage to using that term. And I'm wondering if renaming it functional neurological disorder in any way kind of entrenches or endorses these kinds of diagnostic ambiguities rather than getting us further along in our understanding. And I'm curious to know what you think about those two things.
Well, I'm definitely against the functional neurological symptoms disorder. I think isn't that the latest version? I'm against that, though I've actually written in support of it. I wrote in support of it because it was a kind of consensus statement, and I happened to be the first author of it. But I'm there you go. We're all riven with ambiguities and confusions on this. I'm against it because I think conversion disorder is actually pretty good. And that's because I'm a psychiatrist, and I think that there is mileage in the idea of a psychological explanation, weak as those may be. I think there's a therapeutic benefit to them, and I think there is a conceptual benefit to them. And that's why I'm quite happy with it. And no one has actually ever looked at conversion disorder and how people feel about it. So I feel that there's no need to move away from it. I've certainly never had a patient say, conversion disorder, wait a minute, that's Freudian, or conversion disorder, does that mean this? Because no one knows what it means. There's nothing on the web. And it's entirely up to you in your encounter with the patient to say, you've got conversion disorder, and this is what it means. Just as it would be if you said you've got functional neurological syndrome disorder, and they'd go, oh, what's that? And you'd have to say, well, this is what it means. The name itself, in both of those cases, is quite empty. Obviously, functional neurological symptom disorder has got all kinds of implications and interpretations that people might be inclined to follow and which you could take advantage of. But I think conversion disorder is perfectly ripe with opportunities for people to explain it in ways that are appropriate to their patients. So I'm very happy with conversion disorder. I think functional neurological symptom disorder is potentially dangerous in all sorts of ways, but I don't think it's necessary to change. In terms of dropping the feigning criterion, I'm definitely in favor of that. I think that the diagnostic boundary is impossible to define, and I think conceptually it's very difficult to distinguish the two. And so it is for practical reasons that I want to drop it, because I think it is grossly stigmatizing, and as long as it's going to be there on the web when patient look it up, they're going to see the DSM criteria listed in any website that talks about conversion disorder. They're going to see that feigning is an issue, and it's only going to supplement this fear that they have that that's really what people are talking about. So I think the long-term implications of dropping it are going to be useful. I mean, there are some potential downsides. You could imagine that you could be hiving off those who are feigning from conversion disorder to refine your research or your treatment studies and things like that. But practically that's not going to happen. And therefore, I think those are only hypothetical risks. So I don't worry about those.